Hello and welcome to this tutorial on the management of depression. Today we're going to run through some of the elements of depression, how we classify it, how we diagnose it, and then based on that classification, how we actually go on to treat it. And that'll be in the classifications of mild, moderate or severe. And this can be done via the DSM or through the ICD-10 and 11, the classification systems for psychiatric diseases, the manuals by which we classify and understand the psychiatric conditions that you'll be diagnosing as a doctor. So my name is Dr Jonathan Iliff. I'm an F1, recently come off my psychiatry rotation and intending to do psychiatry ultimately. But whatever specialty you go into, psychiatry and mental health problems will be part of the bread and butter of your work. So let's crack on with it. First thing to say is that there are 9 classic criteria by which the classifications, at least in the DSM, can be used to diagnose depression. And what we say is that we need at least 5 of them in order to say that yes, this is a clinical depression. And a clinical depression needs to have lasted for at least a couple of weeks, usually much longer than that, usually more. And when we say that we need to have at least 5 of them, there are certain ones which are really important. Particularly, we see common to almost all cases of depression, low mood. We also commonly see anhedonia, which is a loss of joy, of pleasure in the things that we used to find pleasurable, joyful. And finally, fatigue is a very, very common feature. But there's a range of other ones, from sleep to feelings of worthlessness and guilt and so on. So, using the number of these criteria that have been fulfilled, and of course a degree of clinical judgment as well, we come to a classification of it being mild, of it being moderate, or it being severe. And you might want to add in the sense, as it were, of another classification of life-threatening, which will involve additional treatment, considerations for things like sectioning, and more elaborate treatments like ECT, electroconvulsive therapy. But we'll get to that later. So to begin with, let's talk about mild depression. Well, the key to mild depression is to treat it from the bottom up, to think of that biopsychosocial model, to think of conservative management before medical and surgical. And so in terms of that conservative management, what sort of things can we look at? Well, first and foremost, you need to think about lifestyle. You need to think about things like the amount of exercise that this person is doing. Can this person be persuaded to get out there, to get exercising, to get moving, because that will elevate their mood. We know that regular exercise is as good as antidepressants, according to some really lovely trials done in the last 10 years, when done in a proper way. Obviously that's difficult for someone who's suffering from depression, but it's a good place to start. We can also think about sleep hygiene. It's really, really useful. And finally, we can also think about watchful waiting. If this is something that is not really dangerous, in a sense it's not a malignant depression that is leading to something more concerning, then we can watch and we can wait and we can see what happens, especially if the person is not motivated to move and they're at low risk at this point. The other key to mild depression is to avoid antidepressants. There's really no good evidence for antidepressants for mild depression. There's very good evidence for it for moderate and severe depression, and this has been ratified and confirmed by a series of massive meta-analyses, the most recent coming in 2017 with Erickson's team. And so there is vast quantities of really good data confirming the use of antidepressants, but please avoid them, absolutely, unless it is clearly indicated in cases of mild depression. So, when it comes to moderate and severe depression, what are we doing differently? Well, the first thing we're doing differently is antidepressants. So we can use things like SSRIs is the first port of call in terms of mood disorders, absolutely every time. They have the least concerning side effect profile. They are relatively safe, especially in overdose, which is really, really important given the group of patients involved and the alternatives, things like tricyclic antidepressants. And examples of these include sertraline, which would be perhaps my recommended first choice. It has a low side effect profile, doesn't affect the QT at all, is good in MI and ACS, and is an all-round good drug. It's also preferred by the NHS because it's quite cheap as well. Same for citalopram, also preferred by the NHS. It does have a long QT, so you need to think a little bit more about comorbidities. If you have the choice, you're not concerned about a long QT and things like that, you might want to go for escitalopram. It's newer, it's slightly more expensive, but it does have evidence to show that it actually works better, even though it's a very similar drug to citalopram. And also there's fluoxetine, worth mentioning because for younger patients, especially those under the age of 18, it's the only one that's actually licensed. It is the original antidepressant, it still has a really good side effect profile, and it avoids discontinuation syndromes as well because of its long half-life. So, we talked a little bit about SSRIs, and we'll go into the antidepressants in another video. But let's step back and talk about the other mainstay of treatment. We talked about low intensity treatments in the first section of this. And in order to just tap back to that, in mild depression we can use CBT. We can use it in the form of self-help groups, in the form of actual groups where people can go and engage with CBT together, self-help programs where people read books, they follow structures, and also on the computer. So CBT can be delivered in a low intensity way, which is really good for mild depression. But when we talk about moderate and severe depression, we need to deliver higher intensity psychological therapies. And so CBT is the classic and first example of this, but there's a range, absolutely. So it could be CBT, it could be interpersonal therapy, it could be dialectical behavioural therapy for things like personality disorders, it could be couples-based therapy, it could be behavioural activation-based therapy, where the focus is on changing your behaviour and engaging in activities that will lift your mood. So there's a whole range of different options, CBT being the bread and butter of this. And really what we're looking for is between 16 and about 24 sessions over a period of between 3 and say 6 months. And this will engage the person over that period, help them to understand their mind a little bit better, their thoughts, their feelings, and their emotions. And it will be based in the style that particular discipline of therapy does things. So besides our antidepressants and our talking therapies, our basic talking therapies, we can think of higher intensity levels for more severe depression. So for example, if you're more concerned about a patient, you may want to double up on some of those early therapy sessions, say in the first 2 to 3 weeks, then being seen twice every single week, just to make sure that they have that added care, and especially in a period where SSRIs may increase the risk of things like suicide in the very early weeks, although that's actually quite a rare side effect and very uncommon in practice. So what else is there to say? I think it's worth adding what we were saying earlier about ECT, electroconvulsive therapy. So for life-threatening conditions, we need to be applying both the gold standard of care, like we would in all moderate and severe depression, which is SSRIs plus psychological therapy tailored to the patient's needs. But we can also, if we're concerned about high levels of neglect, of suicidality, elements of psychosis, which is a feature of severe depression in a large number of cases, we can think about electroconvulsive therapy. And this might seem a bit beyond an F1, as you will be in the imminent years, but even as junior doctors, you are asked to prescribe this, and you do prescribe this. I did myself as part of my psychiatry rotation, work up a patient and prescribe ECT. So that will require a little bit of research when the time comes, but it's good to be aware of all of these things and what the treatment options are. I think the last thing to say is that there are other options when all else fails. So of course, sectioning and involuntary admission into hospital when a patient is a significant threat to themselves or to others is something to be aware of. Of course, that will be carried out by an ACT-approved doctor, a senior doctor like a consultant, and perhaps a registrar as well, will be the ones to do that. But being aware of it is important so you can flag up people that you're particularly worried about. And also, in a more general sense, when people decline therapy, NICE guidance also recommends the options of things like counselling and also psychodynamic therapy, which is kind of psychoanalytic and originally Freudian in its angle. Unfortunately, these two don't really have any good evidence base when it comes to people who are actually unwell, who have significant mental health conditions, and so should really be avoided if they can, but they are options absolutely should the patient be keen on that, and should there be a solid opportunity of a good outcome. So thank you very much for listening. I hope that you've enjoyed this video. Do get in touch if you want to talk about it anymore. And I hope that you've learned something. I hope that it's prepared you a bit more for what is a very common situation out on the wards and in the community. Thank you very much, and goodbye.